these have a very different mechanism of action. BTK inhibitors essentially, what I tell my patients is that it prevents them from growing, whereas BCL2 inhibitors allow the cells to die. And so because of the very different mechanism of action and a known overlapping side effect profile, that's one of the rationales that we've been using to try to combine them and get a deeper response in all these trials that we've been mentioning. Now that said, most of the time right now, or the most experience that we have with the use of venetoclax in the frontline setting is with combination of an anti-CD20 antibody, in this case obinutuzumab. And this comes from data both from the CLL14 as well as the CLL13 Gaia trials, in which the treatment is given with initially by giving obinutuzumab, and then later on we add on venetoclax, which does require a 5-week ramp up, like Dr. Brander was saying, in order to mitigate the risk of tumor lysis. The treatment is one of the more attractive aspects of the treatment is that it is a finite therapy, and so we tend to give it for about a year, and then patients stop, and then they get monitored. And with this approach, which is chemotherapy-free, a lot of patients are doing very well. It allows them to have many years of treatment-free interval before the need for any additional therapy. And because it's a finite therapy approach, it does allow us, and it gives us the opportunity to reuse venetoclax or this class of drugs if new ones are approved for subsequent lines of therapy. And this is, I think, one of the attractiveness about combining it with BTK inhibitors as well, is that it might allow us also to use these either covalent or non-covalent BTK inhibitors at the time of relapse.
Okay. So Dr. Bhat, what do we know about retreatment with venetoclax? So we've talked about fixed duration. What data do we have about when you re-expose a patient to this class?
Yeah, so this is a very important question, retreatment, because venetoclax plus obinutuzumab in the frontline setting is given as a finite treatment for 1 year. So the expectation is that within that 1 year, they probably have not had enough exposure for the cells to be resistant to the treatment. So retreatment is always a possibility for those patients. What we have seen in trials is that retreatment does well for patients who have had a very deep response to the initial treatment and who have had a longer time for the disease to come back, more than 2 to 3 years. Those are the patients where retreatment works well. This is what has been shown in some of the data that we have at this time. There is actually an ongoing study for the frontline study which gave approval for venetoclax obinutuzumab. The CLL14 study is having a follow-up study, which is called the Revenge-E study, which is actually looking at the same question. What does retreatment mean for patients who have been exposed to venetoclax plus obinutuzumab?
Yeah, I think that's a very important point. What is the PFS2 in these patients? So, Dr. Brander, is there a patient you think is not appropriate for a venetoclax-based combination that doesn't have a BTK inhibitor?
Yeah, so in the front line, as mentioned, with treating with obinutuzumab, the obinutuzumab starts for the first 3 weeks essentially, and then potentially you're adding in the venetoclax for the ramp up. And for some patients, or for most patients I should say, their lymphocyte count usually even by that early on in treatment has near normalized, or at least has lowered to a lower tumor lysis risk. But certainly not always patients with bulky lymph nodes are going to have as much of a lymph node response early on to only obinutuzumab. And so I would say the patients, not necessarily that are completely not candidates, but that you're concerned about and might be more logistically challenging, or you might even consider hospitalizing them for, is if they're remaining even moderate, but certainly high risk for tumor lysis. So very large lymph nodes are still, we don't quite know how to factor in the spleen, but obviously that splenomegaly probably takes a factor there as well. And then I also consider the renal function. So if you're worried about tumor lysis and patients already have chronic kidney disease, which many patients will, both at advancing in life or other various factors, those are patients where I have a heightened concern. And so if it's not combined with the BTK to even more debulk first, might be concerned about starting venetoclax in the frontline setting. In the relapsed refractory setting, the venetoclax concern, in my mind, it depends how their disease is progressing. And if they're coming off of a BTK inhibitor progression, sometimes that switchover can be challenging. So again, not completely not a candidate, but we just have to be cautious that those patients with more rapid disease progression as well as bulky disease are higher risk.
I will add here that with BTK inhibitors, we always talk about cardiac risk. However, venetoclax in patients who have congestive heart failure, I have seen it often that it's difficult to monitor them for TLS risk. If they're high risk or even moderate risk, for the TLS prophylaxis, we use a lot of fluids for that. So it becomes challenging to give them that amount of fluid if they have underlying congestive heart failure. So that's where also I have had challenges with venetoclax, especially initiating venetoclax in those patients. So usually we admit them, have cardiology on board, use fair amount of Lasix in those patients. So a lot of services are needed in those patients.
So I think that last point, maybe strike a chord with places who maybe they don't have a cardiologist that they work with or a hospital bed that they can really assess. And that adds like an extra layer of work when you're trying to treat a patient. And again, as you pointed out, may steer you to another option, which requires less intensive monitoring of these patients.
To add to that point about cardiac risk as well, the rates of infusion reactions with obinutuzumab are also nothing that can be ignored. Some data coming out of ASH that I was really excited to see is that we know that if obinutuzumab is added later on in combinations of therapy, in particular if patients have been pretreated with a BTK inhibitor, some of that risk is mitigated. However, infusion reactions in someone with cardiomyopathy also needs to be taken into consideration.
So Dr. Mulvey, one question for you. We talked a lot about genomic factors, 17p, p53 mutation, IgG mutation status. How does that impact your sort of choice when you're looking at VO or maybe one of the doublets that have been sort of put to the forefront, like a BTK inhibitor and venetoclax?
Yeah, absolutely. I think we were all very excited to see the 3-year readout from CLL 17. Still a bit early on, in my opinion. I think that that's an evolving story there. But some of the takeaways that I had is IGHV mutational status is maybe an important consideration in thinking about who you might consider combinations with the CD20 and BTK inhibitor versus combining BTK inhibitor with a BCL2 inhibitor. I think that with time, we may see a little bit more separation in those populations. And then in addition, in thinking about TP53 mutations, I think that historically I had used a lot of BTK monotherapy continuously. But again, I think these are potentially patients where you could consider fixed duration therapy combining with a BCL2 inhibitor. However, based on data from FLAIR, et cetera, I think that doing a year of therapy is maybe not going to be sufficient for a lot of these patients. And it's an area where MRD really can guide your therapy decisions.
Outside of clinical trials and from a routine practice, at this point, I agree that 1 year of finite therapy, let's say with venetoclax or obinutuzumab, is probably not the best in terms of controlling the disease long term in patients who have the high-risk genomic features. We've seen that the progression-free survival for these individuals are still not as good as for individuals who don't have these genomic features, regardless of what treatments you pick. But it does seem like the rate of progression-free survival is better with BTK inhibitors given continuously. Now, that does run the risk of the long-term side effects, the potential for acquiring mutations, and and of course the financial toxicities and so forth. And I think that I'm hopeful as well that we will have more data with combination therapies to see if we can mitigate the risk of these high-risk genomic features with the combination of BTK inhibitors and BCL2 inhibitors without the need for continuous therapies.
Right, I think that's particularly relevant too, because we know that BTK inhibitor toxicities are cumulative, and the longer that patients are on these agents, the more likely they are to develop some of these particularly cardiac toxicities.
Yeah. So, Dr. Brander, Dr. Bhat, so 2 questions since Dr. Mulvey and Dr. Chang have sort of led to this. So, you earlier talked about PFS2, continuous therapy. You would obviously your PFS1 you would assume would be longer than these fixed durations. How important are these studies as they read out with looking at PFS1, PFS2 to make this determination to say, okay, even though I know your cancer may come back sooner, you are off treatments, and that obviously is important for chronic diseases' quality of life, and how that impacts if the PFS2 sort of resembles that. Will that make a big decision in how we manage our patients moving forward?
So I think PFS2 is obviously important for the reasons discussed. I think with BCL2 or venetoclax-based regimen, PFS1 for some high-risk individuals is still important, right? Because we have cared for these patients where they're probably essentially more like venetoclax refractory, maybe if they're relapsing very early. What very early is, whether it's 2 years after or 1 year after, certainly would be very very short. Those patients, I think, biologically just are different, and we don't know for sure, although 1 year might be insufficient, we don't know how many of the patients where longer is necessarily going to, put them in remission and still have a long time off of therapy. I think PFS2 is very important. I think it's going to be challenging, as this discussion has led to, because there are so many options. We might see PFS2 from our own patient cohort or some other, multi-center studies, but in terms of drawing from trials, I think in a good way this has gotten very complicated because how patients are being sequenced and the options they have is just increasingly getting, more complicated.
I agree with that. And previously, when you look at the CLL14 study, there was a study that was presented looking at MRD kinetics while on treatment and what happened to those patients. And if you see that patients were still meeting criteria for responses and all, but those ones who were having slow rise in their MRD while on treatment, those were the ones. So those are the ones where the MRD is already rising within the year of treatment or within a year after completing 1 year of treatment. Maybe those are the ones I would not consider for venetoclax retreatment. Maybe there I would consider something more, a clinical trial, more novel. We know there is a more potent BCL2 inhibitor in clinical trials than rotoclax. Laseptoclax is out there. That is what I would consider in those patients. So I think MRD kinetics in those patients does have a role in telling us the sensitivity of the disease to that particular BCL2 inhibitor.
I was just going to say, just to add on that, not that we have time to delve into MRD as a topic. I think it's a whole session in itself. But of course, that combined with the start of this conversation, the biomarkers is important because we know MRD patients with higher risk or unmutated IGHV might get MRD faster, but obviously their biomarkers along with the MRD are important, but and then also eventually the feasibility of applying MRD to practice, I think, is important.
Just we're not going to dive into it, but just for our audience, just give a brief description of what MRD is, just so everybody's aware.
Sure. So MRD, or measurable residual disease, is measured by various methods and in different compartments. So there's flow-based methods to look at detection of the abnormal cell, in this case, the CLL cell. There are sequencing methods, and so the method and the compartment matter as well. Compartment meaning, are you testing the blood or are you testing the bone marrow? Because depending on the type of treatment and the time from treatment, you might get discordant results. And also, we only really in CLL are talking about it more for the fixed duration or BCL2-based therapies. For BTK monotherapy, we don't usually even really talk about measurable residual disease as a marker because it's so uncommon to get to that by itself. But I think it is important that MRD is incorporated into trials for the reasons we've talked about, because that's how we learn and understand. But the next step of, do you apply it to an individual patient, that's much more complex of an answer.
Agreed.